So we are going to talk about treatment of and diagnosis of congenital toxo. Though it's a topic which the neonatologist is going to deal with, but I think it starts with the pregnant lady. So we are going to start the journey from the pregnant lady onwards to the neonate. If we look at congenital toxoplasmosis, primary infection in the pregnant woman, it's not usually reactivation, it's usually because of a primary infection that the transplacental transfer takes place. And overall global prevalence of infection in pregnant women is 1.1%. France, I think, has one of the highest prevalence of toxoplasmosis in pregnant women. If you go to France, you'll see every third lady has a cat, and they groom the cats in such beautiful ways. So Toxoplasma screening in France is actually standard of care. So they do it for every pregnant woman. Everywhere it depends from country to country prevalence. In India, we don't do it as standard routine of care. We only do it when we suspect toxoplasmosis. Risk of maternal to child transmission depends at the time at which this primary infection is got. So if you get it in the first trimester, the risk of transmission is less. As the trimester increases and moreover towards delivery, the risk of transmission is higher. But the thing is, the severity is more in the first trimester of congenital infection, and as the trimesters go by, the risk of severity in the fetus is much less. Now this slide is very, very important because this will give us a little answers about which test to do in a patient. So if you look at toxoplasmosis, they've said that there are three main strains, type 1, type 2 and type 3, and there are a few atypical strains which is more common in South America. If you look at Europe, 95% of the strain is type 2, and in North America, type 2 is around 43%, type 3 is around 18%, and the rest is atypical. Why is this important? Because on the basis of your strain, your PCR results are going to come. If you look at TORCH titers, we'll be doing CMV, we do a PCR. Parvovirus, we do a PCR, but for toxo, we rely on serology. And the reason is this because of the strains that are prevalent. Not all PCRs will pick up all the strains. And that's the reason why we don't do toxo PCR in a pregnant lady to make a diagnosis of toxoplasmosis. Dr. Dhruv has already spoken on this, clinical manifestations. So if you have an acute phase, most of it is asymptomatic. You will not realize the mother has toxoplasmosis. Most of it is subclinical. The ones who do have symptoms in the acute phase may have fever and cervical lymphadenopathy. Very rarely you may get chorioretinitis. When you get a primary infection, you get specific antibodies and it's supposed to give you lifelong immunity. Only in immunocompromised patients there will be reactivation of the disease. In neonates, it's asymptomatic in 85% of the cases. So if you have a newborn who's born, he will not have any symptoms. These ocular symptoms, the chorioretinitis, the blindness, the macular involvement will take place over a period of time. So it's very essential that you follow up these patients. You will have to monitor their hearing, their ophthal every 3 monthly, at least the ophthal every 3 monthly, because it progresses over a period of time. If there are symptoms present, we used to have a triad as undergraduates. We used to remember hydrocephalus, microcephaly with intracranial calcifications. This is one congenital infection in which microcephaly and hydrocephalus go hand in hand. Usually with hydrocephalus you get macrocephaly, but this is one in which you get microcephaly with hydrocephalus. But you rarely see this triad. So you'll have to look at everything together, whether the child has a liver, spleen, are there cataracts, are there calcifications, is there a bone marrow involvement, is there anemia, prematurity, IUGR, so all these. But this manifestation you're not going to see. Most of the times you'll see an infant who's asymptomatic. So as I said, the ocular thing progresses over a period of time. And you will find two things that you have to monitor is the eye and the brain. So almost 20% of the infants who are asymptomatic at birth will gradually develop eye symptoms, and 9% will develop intracranial symptoms. So Hearing is less, so what you would do is ophthal evaluation 3 monthly till 1 year of age, and then you'll do 6 monthly till 3 years of age. Subsequently, the child will be able to tell you if he's having any problem. BERA, you will monitor yearly till 3 years of age. So even if you have an asymptomatic child, you'll be doing all these monitoring. Now this is one slide which is a little busy, and I wanted a pointer for that. Yeah. Wow. Okay, so when you suspect or do the serology in a pregnant lady, one is you have clinical symptoms like fever in the mother, or some lymph nodes have come up, or there's a contact with cat. You will think of that. You have done a fetal ultrasound and then you found some features which Dr. Rupal mentioned, ventriculomegaly, calcifications. Then you would do a serology test. As I told you, PCR would not be the test that you would do in a pregnant lady because you may miss it. You do a serology, you get an IgM and an IgG negative, right? So it just tells you that there has been no exposure, and because there is symptoms or anything, you may repeat the test and keep on following every trimester and see. If you have an IgG which is positive and an IgM negative, it tells you there's a past infection. If there's an IgG positive, I'm not able to read it. Okay. So you have IgM positive, you have an IgG positive, it tells you that there is an infection, you may need to do amniocentesis. Now these are from the Australasian guideline for infectious diseases. This is what we follow in the OPD. So you will have to go on the basis of your serology. I'm not going to go into these details, I'll tell you. So if you have an IgM positive, that means there is an acute infection. You may decide to do amniocentesis in the pregnant lady. When would you do amniocentesis? Is 4 weeks after the recent infection. 18 weeks, if you can't find the recent infection, then you do it at around 18 to 20 weeks. Now, in the amniotic fluid, you will send a PCR. Why am I saying no PCR in the blood and PCR in the amniotic fluid? Because you have a lot of papers where amniotic fluid is a very good medium for the PCR test to be positive. In the blood, the buffy coat, surprisingly, the PCR tests are not that reliable. So amniotic fluid PCR will give us an answer. Will that change your treatment? Kind of. Whenever you suspect toxoplasma in the pregnant lady, you have an IgM positive, or you did an IgG and you found a 4-fold rise after 3 to 4 weeks, or you did an avidity test and you find it's a low avidity, you may decide to treat the pregnant lady. Now what will you treat the pregnant lady with depending upon the gestational period? So in the first trimester it's going to be spiramycin. The moment you did an amniotic fluid, you may switch over to pyrimethamine sulfadiazine if the PCR was positive. Now, as Dr. Dhruv said, your IgM is going to remain positive for more than a year to almost 18 months. So this is how your IgG titers and your IgM remains positive. So as I told you, you will do a PCR on amniotic fluid and you would do it 4 weeks from the time of infection, or you'll do it at 18 to 20 weeks. If you have a negative PCR, does it exclude? No, it does not, because it could still be that the PCR was not sensitive enough to pick it up. So this is the algorithm that you're going to use. If you have an acute infection less than 14 weeks, you start spiramycin. Why don't we give sulfadiazine, pyrimethamine at that time? Because it can be teratogenic. So you would not be giving it at that time. If you got a negative PCR and a normal fetal ultrasound, you just continue spiramycin. But if you had a positive PCR or an abnormal ultrasound fetal, you will switch to pyrimethamine sulfadiazine. So the moment you have evidence that there is a congenital infection, you immediately shift. If you have an acute infection more than 14 weeks, you immediately start, you're beyond the teratogenic phase, you can start with pyrimethamine sulfadiazine, you do an amniotic fluid. If amniotic fluid is negative, fetal ultrasound is normal, you may switch back to spiramycin, and if it's positive, you continue pyrimethamine sulfadiazine. A little bit about these agents, pyrimethamine and pyrimethamine. Now spiramycin, it just helps in decreasing the fetal transmission. It doesn't work on the fetal tissue. So if you did have a fetal infection, spiramycin is not going to work. And that's the reason the moment you have a PCR positive on amniotic fluid, on an ultrasound which is abnormal, spiramycin will not help prevent the infection in the fetus. So you switch to pyrimethamine sulfadiazine. Now, pyrimethamine and sulfonamides are teratogenic, so you don't use it before 14 weeks. And the dose that I mentioned, pyrimethamine is 50 mg daily, sulfadiazine is 1500 mg twice a day, and you need to add folinic acid 50 mg once a week. A lot of times people ask me questions, it's not available, sulfadiazine, what do we do? Can we use cotrimoxazole? So there have been reports where people have used cotrimoxazole, but you will have to keep in mind the PK/PD data. So what are you going to monitor in the pregnant lady? You're going to do monthly fetal ultrasounds, and you may do a CBC weekly because you're giving these sulfur drugs. And in congenital toxoplasmosis, before I go on to this, I wanted to tell you about the PK/PD data. I think it's in a slide later, so I'll talk about it later. Now, when you are how are you going to treat the congenital toxo in a baby? So whenever you have congenital toxo suspected, you have a baby now who's born, do a thorough clinical examination, check the placenta, do a serology paired IgM, IgG of the baby and the mother at birth, do a fundoscopy in the baby, do an ultrasound of the skull and do a hearing evaluation. Now this is a slide, this is the algorithm that we have devised for our hospital. And this is what we follow in our OPD. It's not something that is there in the guidelines. So we have made it more user friendly for our hospital. You've done a serology of the baby. If the IgM is positive but it's a low titer, repeat it after 5 days. If the titer is negative now, then you just follow the IgG levels and follow serially. If the IgM is positive, you treat it as congenital toxo. You have IgM and IgG both positive, or a PCR, somebody did a PCR is positive. You have some clinical features, or you have an amniotic fluid PCR that was positive, then you consider this as congenital toxo and treat the baby. Now you have an IgM negative, but you have an IgG positive. You go back to the maternal history and see whether the maternal toxo was positive. If it was, you repeat the IgM every 2 to 4 weeks. Right now it's only IgG positive, the baby is not IgM positive. You will have to do a CSF toxo PCR in the baby, and you do an imaging of the brain and the liver, and then decide whether this is congenital toxo or not and treat. If it was no maternal toxo, you have a baby who's having IgG positive, IgM negative, you keep on repeating the IgG every 4 to 8 weeks. So every month or every 2 months, keep on doing it till 1 year of age. If by 1 year of age it becomes negative, then it's not congenital toxo. You don't treat the child, but you monitor. If it is still positive at 1 year of age, it tells you that this is congenital toxoplasmosis, and you will have to do a CT brain, look for ocular and CNS manifestations. You have both mother and child IgM, IgG negative. Then you know it's not congenital toxo, nothing to do. So this is an algorithm that we follow in our clinic. And what would be the treatment of congenital toxoplasmosis? It would be pyrimethamine, sulfadiazine, the doses are there. So initially you start with 2 mg per kg for 2 days, pyrimethamine, and then 1 mg per kg for 6 months, and then you make it thrice a week to complete 12 months. So it's a 1-year therapy. And sulfadiazine is 50 mg per kg every 12 hours, and folinic acid. Now, this is a little bit about the PK/PD data that I was telling you about. Now, pyrimethamine is absorbed completely from the GI tract. It's absorbed slowly. Serum half-life in the newborn is 60 hours. Because it's absorbed slowly, the first 2 days you'll end up giving a loading dose. And then after that, for the next 6 months, you just continue 1 mg per kg. In the CSF, the concentration is only 10 to 20%. That's why a standalone pyrimethamine is not enough. Among your sulfadiazine has a plasma half-life of 12 to 19 hours. So it's a very good drug because you can give it in twice daily dosing. And your CSF concentration is almost 50% of the plasma concentration. So that's why this combination of these drugs have come. Your cotrimoxazole, sulfamethoxazole has a half-life which is almost 3 to 4 days. So that's why you get away with giving cotrimoxazole as prophylaxis in immunocompromised like cancer patients or whatever once a week because of the half-life. So that is not the ideal condition in which you want a baby who has an immature kidney and a liver and you want such a long half-life. Now what happens to these babies with congenital toxo on their quality of life? Well, we don't really have much data on that, what's happened to these babies. But there was one study which I found, and they followed up these babies who are congenital toxo till their adulthood and who had been treated, and they found that they were okay. So there was no problem in their schooling and their cognitive functions were also normal. So treatment really helps them. So this was about congenital toxo. Now just one case that I wanted to discuss. How much time do I have? Okay. So we have a full-term child. So this is a reference that we get from NICU. I think Dr. Alpana and Dr. Forum will be remembering this patient. This is a full-term, 2.6 kilo birth weight. He did not cry at birth. So required mechanical ventilation, was admitted in a outside hospital. They diagnosed him as sepsis with DIC, received multiple FFPs and platelets and blood transfusions. On day 9 of life, was shifted to our NICU for further management. The ID team got a reference on day 20 of life in view of a Toxo PCR that was sent and that came positive. Now, when we saw the child was on nasal CPAP with 21% FiO2, had persistent hypoglycemia on soya milk feeds, extra sugar, IV fluids with 15% dextrose. He was not on ionotropes. The question was, do we treat this or not? So on examination, there was dysmorphism, there was little low set ears, retinogathia. Head circumference is normal, this child doesn't have microcephaly. There is a hepatomegaly. Thrombocytopenia is improving, CRP is 8.2, blood culture is no growth. Bilirubin, there is a direct jaundice there, but the liver enzymes are normal. USG skull is normal, ophthal is normal. And because the PCR was positive, we asked for the baby's titers and the mother's titers to look at the serology. And the serology showed that the IgM was negative in both. IgG in the mother was negative and IgG in the baby was 29.9. So because of the dysmorphic features, whole exome sequencing was done and it picked up some Visser-Brodner syndrome, which is supposed to be associated with some intellectual disability and learning disabilities. The question is, we go back to this slide, should this child be treated for congenital toxoplasmosis? Audience, please wake up. So, shall we have an audience poll? Yes or no? No. Should we treat this toxoplasma at all? Yes or no? You have a PCR positive. IgM is negative, you have a PCR positive in this child. But at this moment in time, will you treat him or not? Okay, so we come to the PCR, Toxoplasma PCR. What is the effect of that? So you can do a PCR on serum, you can do it on plasma, you can do it on whole blood, Buffy coat. And sensitivity in blood samples is only 25%. Okay? As I told you, it depends upon the strain that you're going to do. Now, how do we interpret PCR in this baby? Most likely the PCR is positive. So your sensitivity is less, but it's quite specific. So if you have a PCR positive, it tells you that there is a toxoplasma. most likely has got it through blood products because so much FFP, platelets, blood transfusion is gone. So we consider this as an acquired toxo. And we started the child on pyrimethamine sulfadiazine for 6 weeks. We advised a repeat serology after 4 weeks to see what's happening. Okay, so you will have to be very careful that when diagnosis is not defined in the prenatal age and the newborn is at risk of congenital infection, then please follow up these kids. Don't just take one serology and say it's fine. You'll need to follow up regularly up to 1 year of age. And for patients with diagnosed congenital infections, you'll have to keep on doing cranial screening and ophthalmological evaluation. And most important, how do you prevent it in pregnant women? Avoid eating undercooked meat. Wash your raw fruits and vegetables thoroughly before eating. You've had neurocysticercosis coming in vegetarians. So it's just that the contamination of the raw fruits and vegetables. Avoid contact with cat feces. And a lot of people do gardening, so please wear gloves. So thank you very much.